Dr. Mzukwa, you're still muted.
Sorry about that. Okay. Hello and good evening, everyone. I'm sorry about that. I thought I was not muted. Ordinarily, I would only speak towards the end of the session. But seeing that our chairperson is one of the experts on tonight's panel, I'm really happy to step in as this evening facilitator. Thank you for joining Summer to this webinar and colleagues who are part of this webinar to explore really this important topic, the outpatient management of COVID-19 in Gauteng. As we continue to see alarming numbers of COVID-19 infections, with Gauteng at the epicenter, the management of outpatients is an increasingly necessary function for doctors. Yes, tonight's topic, therefore, is both timely and necessary. Before we get underway, I want again to urge those of you who aren't yet members of the South African Medical Association to visit our website or contact us to find out more about the benefits of joining the important association. There is a number on your screens. I think it will show on your screens, which you can use to get in touch with us. I would like to ask all participants at this point in time to mute their microphones to avoid interference with the speakers. Please do not raise your hand or make use of the chat function, as we are unable to respond to questions raised during the presentations. All questions raised during all questions can be asked afterwards. We're honored, obviously, to have with us tonight 5 eminent speakers who will discuss our topic. Our first speaker is someone who has been at the forefront of issues relating to COVID-19 since it first began, and someone who has been a vocal champion for doctors throughout. I'm talking about the one and only Dr. Angelique Coetzee, who's our current summer chairperson. Let me do a brief introduction of Dr. Coetzee. She gained considerable prestige through her work in the health field, a general practitioner in private practice since 1988. Dr. Coetzee completed her BMed SCI degree in 1981 and her MBCHB in 1985 at the University of Pretoria. Dr. Coetzee holds several diplomas and certificates, notably the Cambridge Advanced Health Management course, which she obtained cum laude. Before entering private practice, Dr. Coetzee worked as a medical officer at Mamelodi Hospital. Since returning to South Africa after 4 years in Ireland, Dr. Coetzee has been an active and involved member of SAMA, including as a committee member of the General Practice Private Practice Committee. As also as a member, as a board member of SAMA, and also was an acting general manager of SAMA. She is, as I mentioned earlier, the current chairperson of the South African Medical Association. Anyone who has watched or listened to news in the past year will know that Dr. Coetzee offers incredible insights into the medical profession, a profession she is also passionate about. Dr. Coetzee says an important element of her involvement with SAMA is to ensure a united SAMA that addresses the professional and remuneration issues of doctors, but also their emotional well-being. With these short introductory remarks, I would like to ask my colleague, Dr. Coetzee, to take this virtual platform with her inputs on clinical treatment as it relates to outpatient management of COVID-19 in Gauteng. Dr. Coetzee, over to you, my friend.
Thank you so much, Dr. Mzukwa. I'm always, if I listen to this, it seems to me it's not me. But thank you so much for those kind words. Before I'm going, I've got a very short presentation that I have prepared. I just would like to say to each and everyone out there, we noticed during this third wave how difficult it was for some of our medical practitioners to treat the patients. We noticed that there is a lot of Facebook, Twitter, you name it, WhatsApps going around, making it extremely difficult and confusing a lot of our practitioners there. We also acknowledge that during the first wave that we said to our members and to the doctors out there, please do not try to see your patients. Try to stay safe. Try to treat them as much as possible over the phone. We acknowledge that. And we also acknowledge that since the second wave and now with the third wave, a lot changed and our experience changed of what and how we need to treat our patients. So coming a full circle, we're back to where we say to the GPs, please see your patients. Please do good clinical care. I'm still off from the old school. You will hear tonight from especially Dr. U Pillay, who's from the new school, the younger generation, how to do it differently if you want to do teleconsultations. But I would like to share with you my presentation. I'm going to go, and please bear with me. I do have my one son here, it's helping me with this, to share this PowerPoint presentation. Here we are. I would, to help to carry on with, I'm trying to see how I move on to the next bar. Just 1 second. Yeah, here it is. I want to share my experience. You have to understand that after the first pandemic, the first wave, we understood that you need to rather to see your patients. So I've been vaccinated. I have, before my I got my Johnson & Johnson vaccines, I did my antibody tests. My antibody tests were positive. Can only be two reasons for that. Either I've got innate immunity, or I got immunity by having COVID-19 without me realizing that. So instead of, in spite of that, I spoke with Prof. Oh God, can you believe it? I think I'm so stressed now. Prof. I'll come now to get now to his surname. It's out of my mind. Slim Karim. And Prof. Slim Karim said to me, Angelique, go and vaccinate. It doesn't help that you have antibodies. You need vaccination. It will strengthen your antibodies. And that's exactly what I've done. So coming back to my own experience in this third wave, I have treated more than 500 COVID positive patients during this past 4 weeks. That is including follow-ups of my patients. That's new patients coming to us as well, and as well as my own patients. I lost 2 patients that I'm aware of. One was an 89-year private patient that got severe COVID. We arranged oxygen for that patient. And as I've said, she's a Steve Biko patient, difficult then to treat her. And she died peacefully in her sleep. The other patient was an 83-year-old medical schemes patient who we sent in with a referral letter. She was admitted to a high care ward and then subsequently removed to a side ward due to the fact that at that stage, it was the family was told that she is improving, which was not true. They actually had to make place for another younger patient, which I do understand. But here I've got a problem, and for all the specialists here tonight, please, if you have a referral letter from a GP, and also knowing the GP, please just alert us that you're going to remove a patient to make space for a younger or a more needed patient, so that we can alert the family and we can start to prepare the family. In this specific incident, the family would have been quite happy if she was sent home and spent the last few hours with the patient. Also very disturbing was every time when the family phoned the hospital, they were told that now she's fine, she's doing quite well. Then the shock is much higher when the patient dies alone in a side ward. So we're also aware, I'm aware of an admission rate of about 10 patients out of these 500 patients that we admitted. So the care that I'm giving in my surgery is based on chronic disease and medical history. Again, a physical clinical examination at my rooms with the necessary precautionary measurements. In our room, it is extremely important that only the patients get into the rooms. We have good ventilation. It's extremely cold in our rooms. All windows and doors, everything that can open is open. And this is extremely important to my colleagues out there. Open up the windows where you can. Stay less than 10 minutes close to the patient. If you're examining the patients, less than 10 minutes, you will still be safe. Wash your hands or sanitize afterwards. That is normal precautionary measurements. Again, as I have said, neither me or my staff are aware that we have contracted COVID-19 up till now. The next part of the care is patient education while you are examining the patients. We first of all had a follow-up of 7 days after diagnosing the patient. We saw them on the day that we have diagnosed, whether it's on site or whether it is a PCR test that came back positive. We then learned that some of our patients, based on age, especially our overweight patients and diabetes patients, need to be followed up 5 days after diagnosis. So there's a special group of patients that you need to see back earlier on a physical examination. Again, I do not do Zoom consultations. I do not do telephonic consultations. I'm still old school. And I try to go back into normal, good practice, clinical decision making that I have learned over the years. So our TRICE guidelines are based on mild versus severe disease. Again, majority of our patients are uncomplicated or mild COVID-19, which can easily be treated at home. Again, I will need to stress it, that it is good clinical examination and common sense that you need to practice when you see these patients. Approximately 30 to 40 of our patients needed home oxygen. Those that needed home oxygen were based on blood gas It was based on a high index of suspicion of our chronic patient that might suddenly progress to severe illness. And it's the dyspnea and shortness of breath observations when walking into my consultation rooms or after being walking from the door, the entrance of my consultation room to the bed. It's extremely easy to notice the dyspnea and shortness of breath. I know there's a 6 minutes walking test that you can do, but in these cases, it is not acceptable. You cannot let the patient walk 6 minutes. The mere short distance from the chair to the bed gives you a lot of information about these patients. We also saw that the oxygen saturation becomes more important from between day 4 to day 12. Again, blood gas determination is a very important factor here. I have asked many times for advice from either Dr. U Pillay, my colleague, or Dr. Viviers. What do I do with a saturation that on a pulse oximeter of about 85 or 88? When do I start accessing my patient for needing the home oxygen? And the answer always is do your blood gases if you are uncertain. Blood gas results for me was a bit of a dilemma the first 2 or 3 times, and I got it. And again, I asked for advice on this, because remember, in my surgery over the years, blood gases were not something that you normally ask for, except for your patients who is suffering from COPD. So what do you do? When do you start with the when do you need your blood gases? What oxygen do you need? Where do you start? But Dr. Peter over here will tell us that a bit later. Something also important that I need to make you aware of, that irregular pulse rate. It is extremely worried if a patient walks about 5 to 6 steps and the pulse rate goes up anything between 115 to 130. What do you do? How do you treat that patient? What I have noticed, that these irregular high pulse rates, the tachycardia, is very indicative of tiredness and a possible myocarditis underlying. It's also important to explain to your patient that if they are severe tired or short of breath, they need to double check on their pulse rate on the oximeter. Also important, what I have seen is that a cough, a chronic cough, the cough or well, it's in this state with COVID-19. If you keep on coughing, if the patient keep on complaining of coughing, double check on the patient's oxygen levels. So tiredness, for me, what I've seen to try to help the patients is pulse rate. A chronic cough that doesn't want to go away. Double check on the SATs. Double check on how active that patient is. For what we have also seen is that during this first few days in COVID-19, you need to let the patient rest as much as possible. You need to train them about the importance of the oxygen levels as well as the pulse levels. I have seen some bradycardia in less than 10 patients, but it is quite alarming as they have no history of bradycardia. I'm still not sure how to interpret that. important to do that. So what do I also do after my clinical examination? So that's the observation, it's the coughing, it's the saturation, it's the pulse rate. What do I do then? I do a few pathology tests. On site, I do the antigen test. It's extremely important if you've got a negative antigen test with a patient complaining of coughing, tiredness, headaches, backache. You know, so very, very suspicious of a cold or a flu. Then, but your antigen test is negative. You have to follow it up within 72 hours with a PCR test, the nasal swab test or the oropharyngeal test, because a negative antigen test with symptoms doesn't help you. You have to follow it. I need to stress this, and this is where I have a problem with the pharmacies or ambulance people doing an antigen test on a patient who is symptomatic, telling them the antigen test is negative, and not advising them two things: to go back to their GP, asking for the 72-hour later PCR test, also not advising them that a negative test doesn't mean a lot in terms of symptoms. The problem is these patients are so happy that they are negative, while they're false negative, they spread this virus to the rest of their family or to the community. I do not do routinely, immediately, a CRP, or a full blood count, or a D-dimer, or a UCE or a UKNE, or a blood case. I only do it where it's indicated. So if it's a young patient that's 21 years old, you really don't need to do these tests. These tests becoming more important the older your patient are and the more comorbidities the patient have. Please don't just go and draw a lot of tests. Use your clinical experience, your clinical high index of suspicion. Also always remember the happy hypoxia, who sounds nice, great to you, flow saturations in your room on the oximeter, and thinking that this patient is actually doing very well. Be aware of the happy hypoxia going forward. Again, on the clinical picture, that's something that I've picked up that's not always described in the textbooks, is check for oral thrush. Oral candida is quite, it's there in at least about 20 to 30% of the patients that we are seeing. Beware of the vertigo, the dizziness, and the bradycardia, as I've said. And while you examine your patient, what I do is I try to explain the symptoms. I need to educate the patient. The better the patient is educated when you see the patient, the less the patient is inclined to go to casualties, to ask for a lot of blood tests, or to waste your time next time with a shortness of breath that's actually anxiety related. Again, I need to stress the importance of fluids and bed rest. So it's in fluids, so that they, make sure that they're taking enough fluids. Make sure that they do bed rest. Make sure that they understand the importance of tachycardia and cough, the importance of an oximeter. So if you can educate your patient will, as I've said, less be inclined to ask for specialist intervention, go to casualties unnecessary, and waste a lot of money. What is the treatment that I normally look at? So patients love to have vitamin C, vitamin D, and zinc. I don't really have a problem. Whether this is going to make a difference, it's difficult to say. There are quite a lot of people that are vitamin D deficiency, so it can't make a lot of harm if they use these vitamins. But as I've said, there's different opinions on that. What I do use is colchicine, 0.5 milligrams, BD for 3 days, then 1 mono up until about 20 days, or now I give normally 20 to 30 tablets, depending on the patient. It quite helps with inflammation. I like to start with prednisone from day 4. You can anything between 20 to 40 milligrams, be either BD or mono. Again, it depends on the symptoms, and it depends on the chronic diseases that the patient is suffering from. Ziframax, there's a bit of controversy about that. Some people say give, others say don't. I'm still of the, I'm still giving Ziframax. Tetracyclines is not recommended. And then I prescribed Xarelto 10 milligrams for 10 days. In my high-risk patients, I will not put a 20-year-old patient on Xarelto that easily. It's expensive, and I just feel that they can then rather use Dyspnea. But Xarelto, for me, very important in my high-risk patients. And then again, finally, it's education, and motivate then patients for vaccination. Thank you so much. I hope this experience that I have with my patients can add value. I do not want to get into an argument about Ivermectin. I don't use Ivermectin in my surgery. As I've said, I've got very good results. I think I've got good results, good outcomes on my patients without the use of Ivermectin. Again, I'm trying to use as much common sense and clinical skills as I've been trained to do, and my experience over the years. For me, the importance of treating COVID-19 patients lie in the simplicity of medical interventions, and again, education, patient education. And then you, as the family practitioner, you need to have a very strong stomach, and you need to have a lot of patience to help your patients. But again, a good educated patient, with a patient that's very well educated, understands much better their symptoms. Thank you so much.
Thank you so much, Angelique. Thank you so much for that. I think that was really insightful, and thank you so much for that presentation. Next in line, I've got our next speaker will be another summer board member, and someone who I believe will offer also important insights into tonight's topic. Dr. Lindy Shange is a specialist family physician who qualified from the Medical University of South Africa, known as Medunsa, in 1990. In 1996, Dr. Shange became a member of the College of Family Physicians of South Africa. In 1998, Dr. Shange attained a diploma in tropical medicine and hygiene from vets. And in 2007, she attained a master's in family medicine from the University of Pretoria. Dr. Shange is a registered specialist in family medicine with the Health Professions Council of South Africa, HPCSA. In addition, Dr. Shange has completed a 12-module course on integrative medicine offered by the South African Academy of Anti-Aging and Integrative Medicine. and she is currently registered with the University of Pretoria for a master's degree in pharmacology. Thank you for joining us tonight, Dr. Shange. Over to you, Madam.
Good evening, everybody. Thank you for this opportunity. I think it was good that Dr. Angelique gave her talk maybe before me, because I think I'm going to give possibly a little bit of an opposite experience in terms of what we see in where we practice. I think where I'd like to come from for this talk this evening is more on the side of practically what we see on the ground in the community and how we manage our patients in the community. Because I found that quite often we've had a lot of webinars where a lot of specialist view and hospice-centric view on the management of COVID patient has been presented. And most of the time, our doctors, GPs, and nurses in primary healthcare are still in the dark in terms of how to manage their patients. So I'm coming from that point of view, looking more at my current experience. So even though I'm a family physician, but I'm working in the community most of the time, and this is where I'm going to share my experience from. My slide is not moving. My slide is not moving.
Dr. Shange, try your arrow keys on your keyboard. Maybe the
Yeah.
left and right arrow keys.
That's what I'm doing. What is this?
Dr. Shange, whilst you, maybe if you could just on your left side of your screen, I think the bottom part, if you could move your mouse around that. Maybe whilst you're working on it, okay, you got it. Are you okay now, Dr. Shange?
Yeah, I'm okay. I'm just
Okay,
trying to,
thank you.
yeah, thank you very much. I'm trying to get to, yeah, there you are. All right, sorry about that. So the first one that I'm going to talk about is when a patient arrives in our place, we have now done exactly the opposite of what Dr. Angelique has explained when she says in her place, she opens up all the doors and everything that can be opened is opened. Initially, when we started treating COVID patients last year, March 2020, that's what we used to do as well. Ultimately, when we had the second wave and when we were moving towards the third wave, we also felt it was becoming too may be dangerous for our staff members to continue to be in a closed environment, even though we were trying to open the windows and the doors, but we decided we would move outside of our premises. Mind you, we are in a building which is about 550 square meters, but we decided to move out and we erected tents all around the practice. We are fortunate to have a space of about roughly 2,500 square meters. So it was easy for us to be able to erect tents. So what we do from the gate, which is important, is to screen the patient. So we've educated we've got a community health care workers who work with us. We've got our staff, the receptionists, including nurses who are working with us in terms of helping us in carrying out the screening questionnaire. So once you're doing your screening questionnaire, obviously you're not going to forget your environmental infection prevention control measures, your spraying, your social distancing. I'm not going to go into that for now, but we'll make sure that that is done, and we make sure that the sitting is done in a socially distanced manner. But the first thing that we do, once we've used that screening questionnaire, then we divide our patients into the green, amber, or red zone. So the green zone will be the patients that would like to fast track so that they spend the least time in the practice. The ones who are coming to collect their medications, your CCMDD patients, Medipost, pharmacy direct patients who are just coming to collect their medications. So immediately after screening, we've got a different site where they move into, and then you make sure you help them and they move out of the practice as soon as possible. So they pick up their chronic medication and they move. The next group that we also like to move as soon as possible out of the practice is what we call the red zone. So those are the ones who, when you do your screening questionnaire, they will answer positive to some of the questions that you are asking, and you know that you are dealing with a possible COVID patient that you'd like not to be sitting and waiting in the queue, even if it's social distancing with other patients in a tent, but you'd like to make sure that they are not sitting in the same space. So we have a different tent where we would take the patient who has answered one or two positive questions to the questionnaire. And those are the patients we also like to prioritize and make sure that ourselves, we have the least contact time with them, but also you make sure that they are attended to as quickly as possible, and then they are moved also out of the practice as possible. But we don't forget to manage our amber zone appropriately. So the others who have answered negatively to the questionnaire does not necessarily mean that at all times they're actually negative. Quite often, they may be sitting in the amber zone. By the time they come to consult with me, then I discover this one should have been in the red zone. So it's not 100% proof system, but at least it does get you to divide your patients properly and quicker and be able to move them through these zones quicker. What I would just like to talk about now, where I've put it in red, to say don't let your guard down with the emergencies. Quite often what happens, once you are busy and you are very clear with your red zones, your amber zones, and your green zones, we are called to say there's an emergency. Someone is brought in a car, or they've been sitting in the red zone, but the condition is changing, or they've been sitting in the amber zone, the condition is changing. I found that these patients, initially, when we quickly move in and we solve them up as emergencies, that quite often at the end of the day, after 1 or 2 days, we actually do discover that these patients are actually COVID positive. So now, what we are trying to do all the time is that no matter how urgent the situation is, we don't let our guard down around these patients in terms of making sure that our PPEs and our infection prevention control measures are in place, because you may get a little bit negligent with these patients. Then the other one is that quite often, as we have been moving through the first, second, and third waves, the symptoms have actually evolved. And quite often, I think for us, we have found that we have had to update our COVID symptoms. Even the questionnaire, we actually have to move with the times and update the questionnaire. Initially, we will be asking about fever, sore throat, and coughs. But lately, most patients don't even have a fever. Most of them just have a headache, they have a rhinorrhea, nasal congestion, and just muscle aches and pains. And they'll come and say, you know, I think I've got sinusitis. My sinuses are acting up again. And sometimes there's no cough, there's no sore throat. So it's always important to update that screening questionnaire according to the current symptoms, and also as we move through the different variants in our epidemic. What I agree with Angelique on is that quite often we would see a lot of the mild COVID patients. Obviously, the moderate to severe ones would have to end up referring to higher centers. But I would like to agree with Angelique in terms of saying the good old history taking, the examination, assessment, and management of the patient is very important. I actually tend to take a little extra minutes just to address the patient's reasons for coming. You always have to find out why have they come, their ideas. They always have an idea about their illness, what they think it is. They always have concerns, they have expectations, and also they might even be having fears, especially around expectations, because when we will talk later about the treatments that we use in the practice, sometimes the patients expect things that we cannot give them. So it's important early on in the management and in the consultation to find out what is the expectation and why the patient has come to the practice, so that we're able to deal with that. And this is where I really find the quotes from Dr. Michael Balint, where sometimes he talks about you as the doctor being the drug. This is where I usually find that sometimes I end up not even giving treatment to patients in terms of physical packets or in terms of tablets taking home, but just talking to patients and dealing with their expectations, fears, and concerns can actually help you. Now, what is important at this stage as well, once you've assessed the patient, whether it's a mild, moderate, or severe, obviously if it's a severe patient, I will take a different avenue, which I'm not talking about this evening, because I'd like to talk about just the management in the community. Now, at that stage, we usually discuss with the patients how to monitor for worsening symptoms and what to do, because these are the patients quite ordinarily which we are going to treat at home. Now, when we send them home, it's important for us to say to them, which are the symptoms that they must look out for in case their symptoms are worsening. And then we give a plan. This is when we make a plan to say, if you suddenly have shortness of breath, or if you have a chest pain that is not responding to painkillers, a fast heart rate, and this is what you do. If we are open in the practice, this is what you do. But this can happen at night and the practice is not open. So you need to work out a plan with the patient, what they need to do. And unfortunately, in my circumstances where I work in the township, a lot of my patients don't have access to pulse oximeters for them to be able to know where their sets are sitting. But in terms of discussing with them their physical symptoms, which might be pointing towards worsening symptoms, is very important. Now, what is also quite important here is to discuss what to do whilst they are being investigated. We also now don't have the luxury of having an on-site testing for our patients. So the question here, when we send our patients for testing, the big question is, what do they do whilst they're waiting for their results? I find here most patients don't understand. When they're waiting for their results, they move around, they only start isolating and taking care of themselves once they get a positive result. And in the 1 day or 2 days whilst they're waiting for their results, in the meantime, they've actually spread a COVID to everybody else. So it's important here to discuss with the patient to say whether you're going to turn out negative or positive. Whilst you are a person under investigation, because now we've suspected and these are the reasons and we're investigating you, please make sure you self-isolate until you get your results. If they are negative, these are the steps you're going to take. If they are positive, these are the steps you're going to take. So quite often what I do here, I'll give a patient a sick leave of about 2 to 3 days to say in the 2 to 3 days, there is enough time for us to be able to know if we are negative or positive. If we are negative, then we know we will depend on your symptoms if we are able to go back to work within the 2 to 3 days. But there's also enough time for us if we are positive to extend your sick leave to the proper isolation period. And then once a patient is diagnosed and they are positive, obviously I agree with Angelique again, we actually give them a plan how to isolate and rest at home, to hydrate well and to take a well-balanced, there's no specific diet that we prescribe. There's lots of diets in the media and also lots of things that patients take. We do not prescribe any specific diets for our patients. If they've got any mild fever or generalized body malaise, we would advise them taking paracetamol. In the past hours, one of the people who were using azithromycin when we started seeing COVID patients in the community. But as evidence-based recommendations came about later, I started changing my stance. So I no longer use the azithromycin in my mild to moderate COVID-19 patients because the evidence now is saying to us, remember, this is a community-acquired viral infection. And so using or adding azithromycin to that standard of care that we are giving them did not really reduce any subsequent hospital admissions or death. Here is your reference I've put in there. So because of that, I have been converted and I'm trying myself and even training even my locum doctors not to be using the azithromycin in the mild to moderate COVID patients. The other one that we also started using in the past year, in 2020, we were using a systemic steroids, prednisone, and also I've been converted in this one as well because the doctors in the higher centers, they say we're actually complicating and making matters difficult for them when the patients arrive in the high care situations. And we've started our patients on steroids on day 1, day 2, and these were mild, moderate, non-complicated patients who did not really need hospitalization. So I've also been converted in this one. My initial scripts, you will see, they would have included prednisones, but my latest scripts now, unless if in later days, as we have seen in Dr. Coetzee's presentation, she had alluded to from day 4 onwards. So what I've found also works now is I would look at the clinical picture of the patient and remember that this is a community-acquired infection. If there is a suspicion that there could be an overlapping bacterial infection, I would use the usual old antibiotics that I would use for a community-acquired pneumonia, for instance, coamoxiclav, amoxicillin, unless if one was thinking of an atypical pneumonia, then I would add azithromycin. But as it were, with community-acquired one, I also did not really see a place for it. But sometimes when you do a chest X-ray, there will be a report on the X-ray and it will say it's an atypical pneumonia picture suggestive of COVID-19. Then I would add azithromycin, but I'm not using it ordinarily with all the patients. And also when we've looked at the evidence in our practice, we don't use hydrochloroquine, we don't use lopinavir, ritonavir, remdesivir, and we are also not using Ivermectin. As Angelique has said, anyway, she doesn't want to go into that discussion. Some of my patients have asked about it, but I haven't had quite a lot who insisted on having it. But as our standard protocol in the practice, we are not using Ivermectin on our patients. The big question is around some of these agents. Personally, all of them, colchicine, vitamin D, nicotinic acid, zinc, and vitamin C, we don't use in our practice. Why we don't use them is because the evidence is very minimal in terms of showing the benefit for using these agents in COVID positive patients. But there's another second reason in our setting. A lot of our patients are indigent patients, and for them to spend that extra rent, which they could have used maybe to buy bread or to buy any other necessities that they need in the house, for them now to go out and try and acquire the vitamin D, nicotinic acid, zinc, and vitamin C, which usually the medical aid, even if they are on a medical aid, doesn't pay for. We always feel with a little bit of evidence that is out there. So we don't advocate for it because our patients are in that situation. And we think if they continue with a well-balanced diet, that should work out. So we don't prescribe these medications in our practice. Baseline investigations as well. I think for people who've got point of care facilities where they can do their full blood counts, UNEs, LFTs, maybe there is a place for doing these investigations. In our settings, we don't have on-site facilities to do this, and we believe that there's no place for doing these investigations if you are not going to act on them. I think for every investigation that one does, you should be saying to yourself, why am I doing the test? And if there's a result, I'm going to act on the results, but on the results, then it's not worth doing it. So I feel it's also not necessary to do them, but the glucose, obviously, one can do a finger prick, as we found most of the patients who were previously not diabetic, suddenly they have this high blood sugar. And that is one of the things that makes us to suspect that there could be a COVID sitting in front of us. But a lot of these other special investigations, we have found there's no place for them in our community care. But if we feel that maybe the clinical picture is uncertain and maybe we need to do more, that's the time when we would refer our patients. ECGs and chest x-rays, the question mark there, with the number of patients that we see, chest x-rays we don't do all the time. You can make a clinical assessment with most of the patients, but for some patients where you'd like to have a clearer picture depending on your examination and there's more suspicion, but it's a patient that you know can get to you, can easily get to the hospital, you will do a chest x-ray, even bronchopneumonias, if we find them on the x-rays, if they are community acquired, we still manage them in the community. So limited number of chest x-rays in some of the patients, but not in all of them. And then the important thing, I'm just going to move fast because I think there was time we used more in the previous one so that we can have everybody else getting their share. The important thing with your discussion with the patient, and I agree here with Dr. Coetzee as well, is that as we are discussing with the patient, the most important thing is to assess for disease severity based on the clinical indicators that you've talked about. So in the practice, then it's easier. You have your sets, it's easy. You look at your respiratory rate, and also temperature, your pulse rate, and all of those things will help you to say, am I dealing with a mild, moderate, or severe case? Now, what is important here is to know when to treat at home and to know when to refer. When I've talked to these physicians and some of the specialists that I've referred to who are working in hospital, the patients who are doing the dying most of the time is the patients where there's been a delay in the referral. So from the side of the doctor or the community doctor is that we may delay in referring our patients, but also the patients themselves, they may fear going to the hospitals and they'll be asking you, oh, doc, if you can just prescribe an antibiotic for me, maybe I'll be okay. I don't want to go to the hospital. So there might be a delay there. And also the patients who've got comorbidities, those are the ones. So I think for us as community doctors, it's important to know when to treat at home, to delineate quicker when to refer to prevent the mortality. And then I'd like to talk lastly about the challenges that we see in the community when we treat COVID patients. During the screening that I talked about, we are now seeing that there's a lot of lying around the answers that the patients give. Patients already know if they say to you, I've got loss of taste and loss of a smell, that you are going to suspect that they've got COVID. So they actually tend to lie. I'm still trying to find out really the reasons why they lie. Sometimes they even lie about your cough. When they are sitting in your area, then you'll hear them coughing, but in the screening questionnaire, they said they were not coughing, then you'll move them. But we think there is a little bit of a stigma attached to it, that patients don't want to be known that they've got a COVID, or they are a suspect, COVID suspect. That's why even now, when we move them into the red zone, we no longer put the tents next to each other, so that the others don't see that, oh, those ones are sitting in the red tent. The tents are situated at the opposite end of the practice, because we've realized that there's this stigma kind of thing attached to it. One of my biggest problems is that since treating the COVID since 2020 up to now, there is no connection between the community GP and the district health in the areas where we work. And I still lament this, and I hope the public health people will help us in the future. Also, I've discussed previously, so I won't sit on this now, that patients have got a poor understanding of what not to do when they are positive. They move around, they hop onto taxis, but also there's a messaging from the lab. Once they are positive, then the lab says to them, contact your doctor or see your doctor. Then they come to the practice and say, I've just received my results from the lab via SMS, it's positive. And I think here it must be clear that there should be other ways, because when they come to you with a positive test on an SMS, they have traveled in a taxi. How many people have they infected? They come even before you screen them. They may have been sitting in the queue with other patients as well. So I think our messaging here must actually be clear of what to do. So in our practice, luckily, during that initial consultation that we talked about, we give them a practice SMS WhatsApp number where they can contact us should the test be positive, but the doctor always gets the results as well. But we have already given them a plan of what to do if they are positive. So by that time, most of the time, we prevent people coming back once the tests come back positive, because in that initial consultation, we've already made a plan for them. And then we also having a problem of close contacts of positives who just decide they are not going to test. You will know, you will have tested someone in the family, someone would have even passed away. When you talk to the other family members to go and test, they refuse flat off to go and test, and they are not really even fully quarantining or self-isolating. So unfortunately, there's no law yet in South Africa for us to force these people, but these are one of the challenges that we have. And then we also have some patients who force and don't want to go and check because they think if they are positive, they don't have enough number of sick leaves and they want to force to go to work. And this is one of the things where we hope employers can help us in terms of saying the patients should be able to sit at home. We've already had a case of someone who forced to go to work even though they knew they were positive, and this person has been criminally charged. So we have to look at that against the socioeconomic problems. But we also have a problem of employers who still continue to request negative results post a positive test, but I've got a way of dealing with them to say the guidelines say patients don't need a negative test to be able to go back. So the last one, which is a big issue, I'm starting to see patients who come with Ivermectin in their bags, and this has been given to them by their employers to say, take this one tablet and then take another one after 72 hours. But the patients, knowing you as their doctor, they will come and ask, doctor, I've been given this medication, what do I do with it? But this is one big problem. Maybe it's not for a discussion for this evening, but it's coming up. And then I think Dr. U Pillay will talk about telehealth, so I won't go into that. This is my last slide. I'm always against patients requesting nebulizing machines. What they do, sometimes they go to discounts and they buy the nebulizing machine, then they come to me and then they say I must prescribe the medicine to put inside. Then I explained to them that COVID is not asthma. This is not bronchospasm. If you cannot breathe, it's because you don't have enough oxygen going into your lungs. So I'm not going to prescribe anything for you to put there. But I'm always amazed when I get to the big corporate pharmacies, there's nebulizing machines at the door being sold. Home pulse oximetry, a few of the patients do acquire, but I don't have a lot of patients who have acquired this. And Dr. Angelique has spoken a little bit about this. Oxygen concentrator, I had about 3 patients who had acquired. Fortunately, they had pulse oximetry, so we were able on a daily basis to help them, monitor them. But in general, this is not my general kind of patient. And as always, home glucose monitoring is important, and most of them, they have this. So I will end there. The other IPC measures I won't go into. I think everybody has spoken about them in many, many different webinars. For the sake of time, I'm going to end there. And the important thing that I would like to stress is the last one. I work in an environment where I work with people who use drugs and people who inject drugs. So for me, it's always important to continue to have the harm reduction measures around these patients, not only these patients, but our chronic patients. It has fallen through the cracks, the follow-up of our chronic patients, hypertensive, diabetes, HIV, TB patients. We just need to make sure that that doesn't fall through the cracks as we continue looking at COVID. Thank you.
Well, thank you very much, Dr. Shange, for that presentation and insight. You've said a mouthful. Now we are heading to our next speaker, the qualified medical doctor from the University of Witwatersrand in 1995, and is currently the CEO of the Independent Practitioners Association Foundation, IPEF. Prior to this, Dr. Untitled Pillay was the CEO of the Alliance of South African Independent Practitioners Association, ASIPA. He's also the chairperson of the Digital Healthcare Association of South Africa, and serves on several boards, including the Synthropy Health Advisory Board and the Discovery Health Family Practitioner Board. It gives me great pleasure then to welcome Dr. Pillay to the virtual platform tonight to talk about the role of telehealth in the outpatient management of COVID-19. Dr. Pillay, over to you, my learned friend.
Thank you, Chair, and good evening, colleagues. So I know Angelique always refers to me as new school and her as old school, but I think I'm a mix of both. My practice is pretty much 80% like Lindy's practice. I have the very same challenges she's having, and I manage my patient almost exactly the same as she does. We have a practice which is a community practice, and the challenges we found was that in the waves, as the first wave, second wave, and third wave came, we had to change and we had to adjust all our protocols, very similar to how Lindy's practice is. The biggest challenge we had was that we found that the minute the patients tested positive, it was difficult for us to separate the patients who were positive from the patients who were negative in the waiting area. We also moved our waiting area outside. And the biggest challenge is that, the patients have to come by taxi. Most of my patients travel in groups. And while we're still seeing COVID patients, we also have to make sure that, we're managing our normal patients, our baby clinic, our antenatal patients. We didn't have the same space that Lindy had. So we started looking at telemedicine to manage our patients, and we formed a bit of a hybrid solution. 80% of the patients are going to be managed exactly the same. We see them, we examine them at the practice, we refer them for a test. We do have on-site testing, PCR testing. And the minute that we do the counseling and we send the patients off, we provide them with a sick note for 2 to 3 days. But thereafter, we don't bring the patients back. The minute the patient tests positive, we move into a hybrid solution of a telemedicine where we then manage the patients using telemedicine. 20% of the patients probably is more similar to Angelique's practice. These are patients who usually contact us first. They contact us either and say they've tested and they're positive, or they contact us and say that they have the symptoms and they're afraid to come into the practice and they would want to do a telemedicine consult. So on the talk now, I'm going to focus a lot on that telemedicine on the 20% of the patients that we manage. Chair, please tell me if you can see my screen. So
yes, we can see your screen, Dr. Pillay.
Thank you. So when we manage our patients, and these are the patients that we manage predominantly 100% by telemedicine. So I'm going to just do a brief history on telemedicine and show that, telemedicine is this, COVID's been a stimulus for change for us. There's been a massive uptake of telemedicine solutions globally. South African stats pretty much mirror what's happening in other countries that, pre-COVID, it was minimal use. And we've seen this massive increase last year in 2020. It's decreased again after the first wave, picked up during the second wave, and we'll continue seeing this. I think what's important is that telehealth and these digital health solutions, M Health, these are solutions that we saw as an opportunity to protect the doctors. We saw this as an opportunity to protect the patients. And I think this has been a global phenomenon. I think what's very important is to just briefly go through what's happened with the Health Professional Council guidelines. So, COVID's allowed the guidelines to be updated. We saw the terminology changing, where we saw telemedicine being replaced as telehealth. The health professional guidelines now allowed for a charge and fees to be charged for services of telemedicine. And I think the very important one, and this is the one that most of us were concerned about, was that up until COVID, telehealth or telemedicine was something that was done from an urban to a rural area, and it was done for a patient that who was not previously a part of your practice. So it had to be an established person, it had to be a patient that you knew, and then obviously COVID changed this for us. So the guidelines which were adjusted in the 3rd of April basically said that telehealth should preferably be practiced in circumstances where there's an already established practitioner-patient relationship. However, if this relationship does not exist, the practitioner may still consult using telehealth. And this opened a door for most consults in telemedicine to be done with patients that were not known to the practice. So what are the reasons why we think telehealth is here, and what are the reasons why we see this massive growth in it? Obviously, it's convenient for some people. We see that you're allowed to do a lot more access from home, especially in the lockdown 5, more and more patients were looking towards telemedicine and Zoom and WhatsApp. Obviously, with the waves, we've seen the continued use of telemedicine, telehealth, and as we go into the 3rd wave and the 4th wave and future pandemics, we're going to see a bigger growth in telehealth. And again, this is very important because we use this solution to both protect patients and healthcare providers, but it's also because the technology is changing. We see new solutions where, initially we said, we should only use telehealth for like your follow-up visits, but we've seen that as the technology changes, that we've seen devices where we can do acute consultations. We are now have a solution in South Africa where we can do a virtual hospital at home care. And all these solutions are now enhancing this whole new age of how we see patients and where we go from here. I think a very important thing that people should realize as well is that both NHI and Universal Healthcare have proposed using telehealth and telemedicine as a foundation of how they see patients going forward. So this is not just something for, a niche market of practices. We will see telehealth and telemedicine as a part of NHI going forward as well. The ability to access to rural areas, I think this is important. As the resources are limited and specialists are limited to rural areas, telehealth has the opportunity to provide care. Globally, one of the biggest growths in the specialty has been in mental health. The psychiatrists, the psychologists have embraced telehealth, and at one stage, I think 100% of all consultations in lockdown 5 in psychology was done using telemedicine solutions. Obviously, it's also about cost, and I think cost for patients, cost for funders have looked at telehealth as more cost effective. There are challenges where for the practitioners, we see this as obviously a decreased fee, but as we have these ongoing discussions with the different funders, and what we've seen in some of the countries to the north, is that telemedicine and face-to-face consultations are now becoming one and the same thing. And more funders are looking to pay a higher rate or the equivalent rate for a telemedicine consult. And I think this is something that we as practitioners will push for. So I think what's important is when we're looking at telemedicine and telehealth solutions is to look at this, what we call these digital care partners. But it's important to understand that each practice is different, and we need to understand that, as we have a GP population that's quite an aged population, we need to look at how does this solutions, how does this digital healthcare fit into your practice? And we need to make it as part of the process that we have, as part of the day-to-day process. I think as more practitioners, and Angelique, as you use more of these digital solutions, you'll get more comfortable with it. I think that's the important part. I think if we're afraid of this and we're not using the solutions, it's always going to be a challenge, and it's always going to be something that we can't use. I think what's important for us as providers is to analyze all the different solutions. When we started this digital healthcare solutions in 2017, it was way before COVID. We didn't realize how massive telemedicine is going to be. But at that stage, there were 4 digital solutions in South Africa. During COVID, that mushroomed, and we got up to 30 to 40 solutions currently that were providing and offering telehealth solutions. So look at what works. Look what works for your patients. Look what works for you. Most doctors are using WhatsApp, and I think that's worked well. There are some very formal solutions. We have a very formal platforms that can be used, but I think when it's really busy, when practices are busy, the telephone and WhatsApp are quick, patients understand it. And that's a form of telemedicine. If that works and that is manageable, understand the limitations in WhatsApp, understand what you need to do to add to and to protect yourself medico-legally. But I think a lot more patients are comfortable with WhatsApp and are comfortable communicating with their doctors with WhatsApp. And we'll see a growth there, but we'll also need to understand what are the limitations. A lot of doctors feel that, they don't want to do telemedicine. The time that they spend on telemedicine, they could spend on a normal patient and get paid more. I think this is important to understand that when we're looking at telemedicine, try to allocate time. Allocate times in your practice when your practice is quiet. Allocate times in the mornings or the afternoons before your patient rush comes in. And I think if you set a specific time when you're going to do telemedicine and you're using those specific times as specific for telemedicine, it will become a part of your practice. It will become a part of every day how we see patients and what we can do with our telesolutions. There's also a difference between what we call synchronous and asynchronous solutions. And again, I think this is important for doctors to see what works for them. The synchronous solutions are just your live solutions where you're doing a video call or you're doing a telephonic call with the patients and you're discussing them. Obviously, you can get a lot more information from a video call, but it's not always necessary. I think a good doctor who does a good history and sticks to the basics like we've heard in the first 2 lectures will get as much information from a telephonic consultation as they would from a video consultation. We're probably going to see a lot more growth in the asynchronous part. This is where patients are able to take their own readings, their own vitals, using a lot of these home monitors and wearables, and then submitting those to doctors. I think we're not there yet as a solution, but when we're mixing synchronous and asynchronous solutions together, and you're able to understand the differences, then it's easy for us to manage our patients better. I think what's important as well is that with all these solutions, the interoperability of the systems are important. Try to find a solution that fits into your practice, that works with your billing solution, that works with your electronic health records. I think the reason a lot of doctors are frustrated at the moment is that we've got too many systems out there and the solutions are not speaking to one another. And as a result, we tend not to use them. So in my practice, 20% of patients that we see, we manage them very similar in terms of how we would manage our patients that are in our face-to-face. Typically, a patient would contact us via telephone, WhatsApp, or request a formal virtual consult. And then we do a full-on medical history. What we do is we have our electronic health records open in front of us. So, we're not doing this telephonic consult and not making notes. I think this point is very important, that if you're doing any form of telemedicine or video consult, it's very important that you have to do clinical notes. Medical legally, I think it's important, whether you're using WhatsApp or not, to make sure that you're doing clinical notes, either in your paper files, or what we do is we have now moved to an electronic health record. So the consultation takes place, the electronic health records are open at the same time, and we're busy typing in exactly what the patients are telling us about their history, what their symptoms are, and what we do. For our referral, there's some good referral forms that we can send. So you can either just send the form. MPAT has a very nice link that if you know the patient's ID number, you just type it into the MPAT app. And basically from the app, you can send a link to the patient's via SMS or email. The patient then completes the link, goes with a reference number to any MPAT lab, and there's no forms or anything to fill it. So it does streamline the process. I tend to use the MPAT link quite a lot. I find it quite easy. Literally takes me 5 or 10 seconds to complete. I copy and paste the ID number into the app, and I send off a link to the patients to do the form. And this is for PCR that we normally do. So those are the patients that are not positive, they've contacted us, and we then send them off. We then put them into quarantine until the results come back, and via the electronic health records, if we need to, we'll send them a sick note. The minute the patient's test comes back positive, that's when we really start a full engagement with telemedicine. We will phone the patient, we will contact them, we will send them and email them an info pack about quarantine, what they need to do. And it's just easier when we send it to the patients in the pack, because often when we counseling the patients, they're not often hearing what we're saying, they're a bit panicky, they're a bit anxious. So we always like to make sure that we send the patient something in writing as well, and we do that by email. I think what's very important is to once again, take the history again. The patients that we've not seen or don't come into our practice for any examination, for us, it's compulsory that they must make sure that they can get a pulse oximeter. If they can't get a pulse oximeter, or they can't afford to get a pulse oximeter, then those patients we can't manage in our space, and we want those patients then to come in. The patients, majority of my patients that we manage on telemedicine have managed to get pulse oximeters. Some of the medical funders are now paying for pulse oximeters, and I actually prescribed the pulse oximeter in my first baseline script that I sent to the patients. So to make sure that every patient has a pulse oximeter. We had challenges in the first, maybe second wave, where there was shortages, but in this third wave, majority of my patients have managed to get pulse oximeters. What's important is that we stick to the basics. We do send the patients a baseline script once they test positive. And that script is more similar to what Angelique has alluded to in her practice. I do give colchicine. I give the patients a Budaflam inhaler, and we put them on the multivitamins. Again, I agree with Lindy that it's not for all patients, and you have to understand the patients from an affordability point of view. But really, the 20% of patients that are reaching out to us for telemedicine consults are patients who are on medical aids that usually would cover this, or the patients, if they are, and we always check with patients if they can afford it, we send them the scripts, they usually get the medication, and they do start the medication. The first week, I think it's very important because this is the viremic phase. And again, also like in the second wave, I was using azithromycin or Zithromax. I've stopped that. We were giving prednisone a little bit earlier. I've stopped that as well. So we stick to the basics. We stick to monitoring the patient. I get feedback from the patients twice a day. And what I ask from the patients is I want to know their temperature, the pulse oximeter, their heart rate, and occasionally if I can, and the patient's a good patient, I'll get their respiratory rate as well. So when I get these vitals back, for me, this is an important part because I can manage the patients in that first week quite well. I can monitor and see how they're progressing, if they're still having a temperature. And in that first week, definitely I don't do any steroids and I don't do any antibiotics. Day 6, I think, is an important part because the pneumonic phase and the pulmonary phase really starts thereafter. And for my high-risk patients, I do baseline bloods routinely. So, you know, if they're elderly, if they're diabetic patients, if they're high BMI patients, then I would do the routine set of blood tests. And I do tend to do a bit more blood tests because I haven't examined this patient physically and I need to understand what's going on. So I do all the inflammatory markers. I do a CRP, interleukin 6. I would do the ferritin as well, full blood count, UNE, and I would also do D-dimers at this stage. Depending on the results, then will depend whether I add on additional medication or not. I think when the interleukin is elevated, when the CRP is greater than 50, the interleukin is greater than, high, that's when I do add steroids. The dosage usually is about 40 milligrams BD for the first 3 days, then I taper down to 40 milligrams single, and I also then look at the D-dimers. I think, again, if the D-dimers are greater than 0.5, I would look at adding Xarelto. But I think what's important is that, you know, this is not a template that you can put for every patient. You have to understand the patient. You have to monitor the patients well. You have to know what the risks are of the patients. And I think if you are going to be using Xarelto, it's very important to make sure that you explain that the medication is an anticoagulant and what are the risks of bleeding. I do then ask the patients to continue giving me their vitals on twice a day for the full 10 days. And this is very important for me, especially in the second week, because that's when the patients, if they're going to desaturate, we start noting them. A lot of my patients, and at any stage, you know, I'm managing between 20 and 25 patients on telemedicine, so it becomes quite complicated. But a lot of my patients in that patient base do have pulse oximeters, and a lot of them also have oxygen concentrators. So we do manage patients if their sats are dropping below 90 and they're being able to manage their sats on an oxygen concentrator. We try to maintain them above 95 on a concentrator at home. I think what's important is to understand, and for patients to understand that, you know, the concentrators, what we've seen is that there's a lot of cheaper quality concentrators out there. And we need to be very careful because often we've realized that when we put patients on cylinder oxygen, their saturation's at 98, 99. Obviously, it's a higher concentration. And often we've had patients who've used concentrators where their sats are not going above 90, 89. When we've changed the concentrator, we're getting to 95. So I think that's very important if patients are out there. I think a lot of patients are buying concentrators. There's a lot of community organizations that's renting them out or supplying them. Is that the quality of the concentrators, unfortunately, we've seen there's a lot of poor quality concentrators in the market. And it's important to understand that when we're giving patients oxygen at home. For my patients who are high risk, again, I then monitor the patients with follow-up bloods. And I tend to do this every second day or third day, depending on how bad the results are or what I've added on. So if I've added Xarelto on, I do want to monitor my D-dimers. I want to notice if my CRP or my interleukin is increasing, is there, you know, a cytokine storm developing? And I think, you know, this goes back to what Lindy says. The better we can monitor our patients, the better we can monitor the bloods, the better we can understand their saturation, the quicker we can understand if a patient is going to land up in trouble, which means, you know, we need to understand and be comfortable, be experienced enough with managing these patients so that we know when to refer. The whole point of telemedicine is not about keeping the patients and not out of hospital indefinitely. There are patients that are going to need hospitalization. And I think it's very important for us to understand that the red flags that are in a face-to-face consult are exactly the same red flags that you look for when you're doing a telemedicine consult. Obviously, the nice things about having an electronic health records is we do our sick notes from there, we do our radiology and X-ray referrals from it, and we also do admission summaries from it. I always worry when doctors are telling me they're using WhatsApp only, because I think that, if ever there's a medical legal case in 5 years or 10 years time, are you still going to have a record of that WhatsApp? And if you haven't saved your WhatsApp and you've moved phones, it's very important to understand that WhatsApp information that we have must be transpired into some form of clinical notes in our practice. And I think an electronic health record going forward is something that all doctors should look for. So the basis of telemedicine, I think what's important, and I know Angelique will agree with me on this, must be exactly the same as a face-to-face consult. When you're doing a telemedicine consult, a history is very important. Come to a diagnosis, understand how you're going to manage the patient from a therapeutic point of view, understand what the monitoring is going to be, whether it's blood tests, and I think understand what that follow-up is. Telemedicine doesn't replace a face-to-face consult, and telemedicine is not the be-all and end-all of GP consults. It's not going to be the death of consults. I think telemedicine, for me, is an adjunct to how we see patients. In my practice, for COVID, it's 20%, but for non-COVID, it's probably 10%. Majority of my patients are still seen face-to-face, and I think that's going to continue. I don't think telemedicine is ever going to replace a face-to-face consult for doctors. So this is my last slide. I think here I'm just going to read this as something to end off with. I think the COVID crisis has significantly impacted the whole patient care paradigm. I think its ripple effects have changed patients' behaviors and their expectations. And I think this is not just for COVID. I think going forward, we're going to understand that patients are now going to look at how they access healthcare very differently. And I think it's very important as healthcare providers that we understand this, we understand the change that's happening, and that it's important that we engage with our patients and we support patients, in this journey of telemedicine going forward. Thank you, Chair.
Thank you very much, Dr. Pillay. I must say that I'm really honored and privileged to have worked with the 3 previous speakers as well. I know them to be hard workers in what they do, very dedicated to the healthcare. All of them also being activists in terms of, looking at the current situation of healthcare in our country. Now, thank you so much, Dr. Pillay. That was a very insightful presentation. I would like us to move forward. Just at the end of this, we are going to have a survey of about 10 questions. It will be displayed on the screen so that we can participate just at the end of this webinar. Moving forward now, I would like us to welcome our next speaker. Our next and final speaker for tonight is Dr. Piet Viviers, who currently works as a consultant pulmonologist at Life Wilgas Hospital in Pretoria. Previous to that, Dr. Viviers was a fellow consultant at the Department of Internal Medicine in the Division of Pulmonology at the University of Pretoria. Dr. Viviers attained his MPCHB from the University of Pretoria in 2002 and his M.Med Internal Medicine cum laude in 2009. He also holds a certification in pulmonology from the Colleges of Medicine of South Africa. Lastly, Dr. Viviers is a fellow of the American College of Chest Physicians, and he joins us tonight to talk about oxygen therapy in outpatient management of COVID-19 in Gauteng. Over to you, Dr. Viviers, the floor is yours.
Good evening, and thank you so much for the kind introduction. Please apologize my voice. I've got a bit of sinusitis, and I promise you it's got nothing to do with the virus. Firstly, a disclaimer. I think when talking about oxygen therapy, it's become very important. It's not something that out-of-hospital doctors are very used to using. I think many doctors have been thrown out of their comfort zones, as it were, because it's not something you're used to prescribing. So the first disclaimer would be that I honestly would say a patient requiring oxygen should be referred to a hospital. Previously, we would never dream of treating a patient at home, especially if you go the telemedicine route, to simply prescribe oxygen and let them go home with their own device. We would never have dreamt of that before. But because of the sheer number of admissions and the resource limitations we have, we were forced to do that. We were forced to treat patients at home, which is not ideal. So I'd first and foremost absolutely advise you to discuss that with patients, that if at all possible, if you realize a patient needs oxygen, rather refer them. Even if they end up not being admitted, they should be evaluated at a casualty unit. You would ideally want to do a scan in these patients, risk stratify them, and then decide who to admit and who not. So having said that, I appreciate the fact that it's not possible for everyone to go to hospital. What we certainly see in many of the Pretoria private hospitals is that there is bed capacity. We can admit ward patients, but our largest burden is in the high care and ICU settings. So we certainly have space to admit the patients that require oxygen therapy. And I think one of the reasons, as alluded to one of the previous speakers, I think it was Dr. Shange, that said patients arrive very late, and that's absolutely true. So they are afraid to go to hospital. They would rather self-treat at home. And then when things get really bad, they go to hospital and they then need ICU care. So we certainly have capacity to probably look at some of these patients at certain hospitals. We do have bed capacity for those. Our problems really are with the very severely ill ones. And there's not much we can do about that at this stage, but ride the wave. So how would we go about determining whether patients need oxygen? So talking about this, there is a discrepancy between dyspnea and oxygen requirements. So that's the first thing to recognize. Patients can be hypoxic, but not dyspneic, and the other way around. So certainly you want to see within your first evaluation, whether it's in person or via a teleconference, you want to see if that patient is actually dyspneic or not. I think that's the first most important thing. Decide whether it's mild, moderate, or severe. Mild, a patient can still go around their daily living. They're independent. Once we move to the moderate dyspnea, patient that cannot climb a flight of stairs, cannot dress themselves, cannot cook their own food. So those would be the quick questions to ask. That would be a moderately dyspneic patient. Severe dyspnea would be the patient that's dyspneic at rest. So if you are doing your video call or seeing your patient in person, a patient that's out of breath while speaking to you, they cannot sort of finish a question without pausing, that patient should be referred regardless of oxygen saturation. All right. So once you have severe dyspnea, you are at risk of developing, you probably already have parenchymal lung disease, because that's really what we want to know. We want to know, is there parenchymal lung involvement? And there's no biomarker to tell us that. As long as your COVID disease remains an upper airway problem, causing sinusitis or cold-like symptoms, we probably know you're going to be part of the 85% of patients that are going to be just fine being treated at home. But you really want to know who the patients are going to be, that 15% or 10% group of patients that will progress to parenchymal disease, COVID pneumonia, and eventually ARDS. So severe dyspnea would be your foremost marker, and it's something you clinically will pick up if you talk to your patient. Some patients will be mildly dyspneic, but will have low saturations. And what is a low saturation? Well, the WHO and the CDC will define it as a saturation below 95%, which personally in Pretoria I view as too high, simply because we live at a high altitude as well. So most normal people have saturations between 94 and 96. So I would suggest a cutoff limit of about 92. And certainly patients with a saturation below 90% need to be seen in person. I do not think you should treat a patient with saturations below 90% as an outpatient, regardless of how good they feel. Oxygen saturation monitors, for me, it's a curse and a blessing. It's a two-edged sword. Number one, they are costly. They do cost money. They used to be expensive before COVID, and they got triply expensive after COVID. So I think most of our patients in the primary care setting will not be able to afford them at all. For those who can afford them, it's important to teach your patient how to operate them. So there are factors that can decrease the saturation spuriously without there being a real problem, and there are factors that can increase the saturation falsely. So patients need to sit up or stand, preferably if they can. Take deep tidal volume breaths for a few seconds. Make sure the finger is nice and warm, and then measure the saturation over a period of a few seconds and a few heartbeats. So if the fingers are cold or they do a test very quickly, they might get a falsely low result. Patients who are anemic might have a falsely low result. And that's sometimes a cause of neurosis in patients. I get called daily about your patients with saturations of 83, 84. And when they come into the practice, the saturations are 94, 95. This commonly happens. There are also, unfortunately, reasons why a saturation probe will overread. So patients who are heavy smokers with carboxyhemoglobin can overread. So they can have a falsely elevated value. Dark-skinned individuals, certainly darker skin can also increase saturation values. And then diabetic patients, if your HbA1c exceeds 7%, you will also have a slightly increased value of your saturation. So those are the pitfalls that you need to look at before evaluating the value, if you can use it. Clinically, I think if you see your patient in person and then follow them up every 2 or 3 days via the telephone or via video stream, I think that's probably the best indicator of when patients are doing poorly and will require additional help, more so than just a single saturation reading. So I think it is an adjunct. It can be used in addition to your general history taking and as part of your clinical assessment of the patient, but it should not be used in its own right. And certainly blood gas parameters, as Angelique talked about before, that is a very nice thing to have and to do, but it will not be available to the absolute large majority of patients. It's also a very expensive test, and you have to send your patient to hospital for that. Very few laboratories can have the capacity to do blood gases as an outpatient as part of a peripheral setting. But if it is available, that's always better to confirm findings with a blood gas if you need to. And certainly medical aids only fund oxygen once you can prove hypoxia. So you need a PO2 value of below 60 to get reimbursed for oxygen. And I believe in certain medical aids required to be below 55, which is quite low. So once you go the route of prescribing oxygen for home patients and you want the medical aid to pay for it, you might need to do that blood gas to begin with. But I think the most important thing is if you do get to a patient that is hypoxic, the absolute first management decision would be to send that patient to a hospital. There they can work them up in terms of risk factors and then decide admission or no admission. When we discharge patients, we certainly try and arrange oxygen for them because that allows us to discharge them at a much earlier date. So I tend to, in my practice, and this is not evidence-based, but my opinion is to discharge when we reach a level of about 1 to 2 liters per minute, which is about 24 to 28% of supplementation. Once the patients are ready to cope on those low flows, we then discharge them. Obviously, there's a huge delay, and this is one of the other problems where we sometimes struggle. If you apply to one of the oxygen suppliers before COVID, you tended to wait either 45 minutes to about 1 day and you would get your oxygen. We now see a huge backlog of orders and we can wait up to 5 to 7 days to get oxygen delivered at home. And that's another predicament that you would find yourself in if you do diagnose a patient with hypoxemia at home. Even if they're comfortable, even if they refuse hospital admission, it's important to notice that it might take 2 or 3 days for that patient to get hold of any oxygen supply at all. And that certainly will continue to be the case for the next foreseeable few weeks. There's unfortunately no data to suggest the use of any other biomarkers in deciding which patients should be on oxygen and which should not. The trigger for oxygenation, as I said, is a saturation of 88% or lower and a PaO2 of 60 or lower. And we would usually commence patients in the region of 1 to 3 liters per minute if they are treated at home. Once you get to 4 or 5 liters, it gets a bit difficult. If you exceed 5 liters of flow, Number one, that patient really is in trouble and should not be at home at all. And number two, if you exceed 5 liters, there's no way to assure that the patient is actually getting the concentration of oxygen that you're thinking they are. So if you do treat at home, 2 to 3 liters should be the absolute maximum in patients that already declined hospitalization. And there are also such patients that simply say they won't go to hospital because of this and that reason. There's a lot of paranoia, a lot of irrationality that coincides with COVID. It's not just a physical disease, it's a psychological disease as well. It affects human beings at a much deeper level. So there's a lot of fear out there. Social media is absolutely to blame for a large majority of the cases. But I think our role as doctors is to do that exactly, to inform our patients of the truth. I think it's important that science trumps emotion and not the other way around. So certainly if you have these patients that have exceeding or increasing oxygen demands, please make sure they get referred quickly. The case to be made for steroid therapy, absolutely, that would be the trigger for corticosteroid treatment in COVID. So all the trials, and I believe there are about 5 randomized controlled trials now that's been part of a meta-analysis. Patients that require oxygen therapy, those are the patients where you will decrease mortality with corticosteroids. There's very little reason to prescribe a steroid prior to the initiation or the requirement of oxygen. And we tend to give dexamethasone 6 milligram a day, which was based on the recovery trial, which is equivalent to 32 milligrams of methylprednisone or 40 milligram of prednisone. And that would be for a duration of 10 days. And obviously, for a 10-day duration of steroids, you don't have to wean afterwards. The second drug that's now being used to try and attenuate the inflammatory response, anti-interleukin 6, which is Tesolizumab, recently been approved based on 3 randomized controlled trials. We've had the drug available to us for a good few months. Some hospitals already using it as soon as the end of 2020. But some of us did wait for trials to confirm its use. And we've used it since about March of this year. And the same trigger applies to the steroid therapy. The moment a patient requires high flow oxygen therapy, those are the group of patients that will definitely benefit, with a reduction of mortality of about 43 to 20%. So that was quite a significant drop in mortality based on that randomized controlled trial. So certainly those are the 2 drugs we have available in your armamentarium. There's very little reason to use those drugs outside or preceding a patient that requires oxygen for that time being. Another very important thing to allude to is patients with underlying chronic cardiac and lung disease. So many of our patients with COPD will already have a decreased baseline oxygen saturation. And unfortunately, they're also at increased risk of mortality. So I would not treat a patient at home if they have COVID together with a significant comorbidity, such as COPD or congestive cardiac failure. I think those patients need to be in hospital. So if you risk stratify your patients and they've got any of those high risk comorbidities, there are lists available on the CDC website, but generally speaking, chronic cardiac disease, chronic lung disease definitely qualifies, chronic renal failure, cancer patients, and patients taking immunosuppressive therapy. Those are really the ones that I would not prescribe oxygen at home for at all. They need to be treated in a hospital setting where they can be monitored. Important to consider the risk for venous thromboembolism, absolutely important. There's not a lot of data looking at outpatient anticoagulation therapy. So the mere diagnosis of COVID-19 is not in itself enough reason to prescribe thromboprophylaxis to everybody. Certainly, you can still use the same risk assessment as you would use with any other patient. For example, if you treat a patient with atrial fibrillation, you would look at certain risk factors before you treat them. The same applies here. So for sure, patients with obesity, previous venous thromboembolism, recent trauma or surgery, those are the patients where you would absolutely look at prescribing a drug like rivaroxaban. We use rivaroxaban because that was the one tested in a few trials looking at medical patients. And 10 milligram a day seems to be the appropriate dose. Duration is absolutely not sorted yet, but many sources indicate up to 30 to 39 days of prophylaxis is warranted. And certainly when we discharge patients from hospital, we prescribe additional 14 days of medication for prophylaxis at home. And if you carefully select your patients, we haven't had any major problems. It is important to look at risk for bleeding as well, using something like a Has-Bled score. But I think patients with risk factors, you absolutely, you can look at that. Anticoagulation in terms of antiplatelet therapy, there's no indication to add that onto a patient that have no other indication. So certainly the venous thromboembolism sphere needs to be looked at. And in a patient who suddenly deteriorates, suddenly becomes more hypoxic, over and above ARDS, do also consider the possibility of a thromboembolism. These patients carry a very high risk of this complication. And in one large French study, patients admitted to hospital had a 15% incidence of pulmonary emboli, which is very high. And we certainly don't scan all our patients we admit with the view of excluding pulmonary embolism, but certainly it's something to look for in patients that remain at home. D-dimers can help you, but there's simply no cutoff point you can use because COVID in itself will increase your D-dimer. It is not a cheap test. So it's important to have that conversation with patients where they elect or select to be treated at home. They need to be able to follow this up as an outpatient if they can. So that's my 10-minute worth in terms of oxygen therapy at home. I would be glad to answer any questions at the end. I think there's now a question and answer session, and we would certainly be happy to answer any questions revolving oxygen therapy or in fact management of pulmonary disease. Thank you for the time and for listening.
Thank you so much, Dr. Viviers, for that insightful presentation that was focused presentation. Colleagues, I think we are on our Q&A session, and already I noted that there were a few questions that were asked, and I've already asked our esteemed panelists to have a look at the questions and answer those questions. And I would also like to invite Dr. Pete Viviers to join the panelists in terms of answering the questions. At the moment, let me start with Dr. Angelique Coetzee. Do you want to answer? Are there any questions that you would want to answer live?
Thank you, Dr. Mzukwa. There's not really, I think it's extremely important that Dr. Viviers explained to us the Bidisonite usage, as well as the fact that patients want to nebulize. They want to nebulize with anything that you can put into a nebulizer, from Vicks to God knows what. And I think it's important to get his opinion on what is the role of nebulizing at home in COVID-19 disease, whether it's mild or moderate or severe. What is the importance of lung test, not lung test, lung exercise? Isn't that much more important than nebulizing? But the Bidisonite question is important, and I know Dr. Viviers would be able to answer that. And I have answered some of the questions from a GP perspective. I hear what Dr. Viviers say that, you need to refer, but remember, it's not always possible. So it's always good to have a specialist number on speed dial if you're not sure what to do with your patient, as you can't refer each and every one, and there is no place in the hospitals. Thanks.
Okay, thank you. Can we answer that, Dr. Viviers?
Yeah, sure. I will answer the questions I can. I see there are a number of them. So let's start with the nebulization. We'll group those together. So first problem with nebulization at home, I would not me. This is evidence-based. So CDC, WHO, NIH, we're all in agreement. Nebulization should not be used at home if there's any risk to other people around in that surrounding. So if a patient is living on their own, alone, with a cat or a dog, and that's it, that's fine. You can use your nebulization. But nebulization is a aerosol producing procedure. And certainly in hospitals, we do not do that because of the risk of transmission. If you do use a nebulized therapy, in terms of medication that can be used, there's one trial, this called the STOIC trial, that was published recently. Not a large trial, it's about 140 patients in the United Kingdom, where they used Bidisonite, the one that Rishika Tayop refers to there. They actually used Bidisonite in 800 microgram BD doses, but either via dry powder inhaler. It did reduce some of the symptoms significantly, from about 9% to about 1%. So it helped a bit with the cough. It helped a bit with symptoms, but it did not reduce mortality. It did not reduce severity of illness at all. So it can be used for symptom relief. There is definitely data, even though it is a very small study, and we would love to see more randomized controlled trials being done on that. Personally, I think it's not necessarily an unsafe option. I think it can be tried, especially if there's nothing else that you can add. Certainly in a patient at risk for bronchospasm, so patients with asthma who should in any case be on an inhaled steroid, you should absolutely continue. So explain to the patient, yes, it might help. It might reduce some of your symptoms, but look out for side effects, certainly. And that's the only real inhaled therapy for which we have any data. If you look at bronchodilators, they don't do much in terms of COVID bronchitis. They don't really add much more value. They do make patients tachycardic and make them, give them more tremors, but certainly they are reserved for patients who are actually wheezing. So if your patient is wheezing, bronchospastic, because they have underlying COPD or underlying asthma, certainly you can use inhaled bronchodilators. And that's the limit. We do not use ACC nebulizations. We do not advocate the use of any other inhalers. In winter months, certainly a humidifier can be helpful, and that's par for the course with treatment of any upper airway problem, whether it's sinusitis or cold. Humidifier can be used, and preferably without any addition of any flavorants or any other substances that make it smell nice. You just want a bit of moisture. So keep it simple, keep it cheap. I think that's the very important part. It's getting a very expensive disease. If you're going to write a script with everything that is now being tested on a randomized controlled trial from A to Z, I think there are about 46 drugs at the moment, 46 being either advocated or tested in terms of treatment. It just gets a lot, and 80-85% of your patients will get better despite what you do. And that's the important thing, to get those patients to understand why you don't need all these drugs. You will get better in any case. And that's what they need to do. And all you need to do as a doctor, pick up the 15% who don't. So the dyspneic patients, that's the one you move forward. So certainly budesonide and nebulizations, I hope that answers the question on that. I'm just going to go down quickly and answer the ones that I can answer. There's one question on anticoagulation. Xarelto after 40 days, the D-dimer is still 1.2. Xarelto will affect your D-dimer. All right, so I would not be very concerned. If the patient is completely asymptomatic, I would stop. And if you're very paranoid, maybe just repeat the D-dimer later. Question is, does this patient have an underlying reason for you to be worried? So did this patient have a DVT before? Did they have a PE before? Do they have an underlying cancer? If the answer to those questions are no, it's a healthy patient with no other risks, and the patient is asymptomatic, stop the treatment, give it a month and repeat the D-dimer if you wish. But absolutely, the anticoagulants, the oral ones, will potentially affect your D-dimer values. It will. The same as warfarin. So we also don't do D-dimers on warfarin. So I hope that answers that question. Management of hypoxia breathing, absolutely. Breathing exercises are being reported as one of the home-based therapies that patients should do, and there are various ones. And if I can maybe later on, share that article with you. There are a few things I can do. Incentive spirometry is one thing we do in hospital, where patients use a small Mediflow device. Those devices can be prohibitively expensive, but I mean, breathing through a straw in water 10 times in a row can do exactly the same thing. Sitting upright, postural drainage, all those things can be done by patients as an outpatient, and there are, patient information leaflets available on the net that you can forward to your patients. It certainly helps. Inhaled corticosteroids, I think I answered that question with the budesonide. So certainly in patients who have risk factors for that, you can do it. So would you prescribe on your script for patients discharged from hospital on home oxygen? So when we prescribe oxygen at home, it would be the quantity, which would, as I said, at home would usually be between 2 and 3 liters per minute, and it would be for 24 hours a day. So your script would write O2 supplementation, 2 to 3 liters per minute, or enough to keep the saturation above 88%. So if a patient is on oxygen and the saturation is above 88, that's the amount of oxygen you want to give. There's no harm in giving a bit more, but that might be wasteful. If the patient is using a cylinder, they will run out a bit quicker. But that's very important, that if you do treat with oxygen at home, I think a saturation monitor would be preferable if you go that route. So you just want to know how much do you want to give to get the saturation above 88%. And most of the time, the patient will, in any case, be able to adjust it themselves between 1, 2, and 3 liters. Right. Do mucolytics have a place in treatment? Patients with acute bronchitis and severe mucus production, yes, it is a safe alternative, like it would be in any other chronic bronchitis or acute bronchitis patient. So you can use ACC. It will do nothing for the COVID itself, but it will certainly help mucus clearance, so it is safe to be used. Although I wouldn't inhale it. I know some patients do use it in nebulized fashion, but I wouldn't advise doing that. There are case reports of acute bronchospasm when you use that it's not been tested as an inhaled drug. Is there a benefit to using Alvesco as opposed to Bidisonite? So the data I was alluding to was looking at Bidisonite, but certainly there's no reason to suggest that one steroid would be better than another. So I certainly would agree. Alvesco, which is cyclisinide, I certainly use it a lot. It is a very safe inhaled steroid. It's a prodrug, so it only activates once it lands up in the peripheral airways, and it can be given as a nighttime dose in 2 puffs or more. So I don't think there's much of a difference, even though the trial data we have, it was Bidisonite. You can certainly use any inhaled steroid that you would choose, rather than the nebulized therapy. Just quickly, yeah.
Okay, thank you so much, Dr. Viviers. Dr. Linda Shange, do you have questions you want to answer live?
All right, from my side, I have already answered physically by typing them. It was around after how many days should you be able to vaccinate after having tested positive? And the current guidelines, it says at least after 30 days. And also it's knowing which patients to treat at home and which ones to refer as soon as possible. And also the use of mucolytics. Most places would prescribe mucolytics for diagnosed COVID patients, but personally I don't, but I see a lot of scripts of people doing that. And then the steroids, I would agree, and the current guidelines also say for patients who do not really need oxygen and who do not really need hospitalization, there doesn't seem to be a place for using steroids. And there was a question around whether we do blood gases in our practices. For people who've got point of care appliances, maybe, but in most practices, no. Thank you.
Thank you so much, Dr. Shange. Dr. Pillay, you have questions that you would like to answer live?
Thanks, Chair. I don't see any questions specifically related to telemedicine.
Okay, thank you so much. Are there any questions that I've left that are not answered, colleagues?
There was a question to Dr. Viviers about a patient discharged in hospital who's then, I think it's the one but last question, maybe you can answer it for that person.
Okay.
Yes, I just quickly when I saw it, but I think it's been removed. That was a 47-year-old patient with asthma. Yes. Is that the right one?
Yes, that was the one.
Yeah,
it was fine.
Yes.
And yeah. So I try to answer it as well, Piet, but you can look at it because from my side, if the sats are normal, the pulse rates are normal, there's actually nothing. one needs to double check that that patient is not suffering from anxiety, because we know that's part of COVID-19. So we always try to look for further diseases and further examinations, but the clinical examination very important. But that's my opinion.
Yes.
I would also like you to just ask, to very briefly remark on people who take what do they call it? Oxygen. They use sauna type of thing to open the airways. I'm not sure what they use. There's a term. Lindy, do you know perhaps that term where they use they go into places steaming. That's the thing. And I don't think there's any place for steaming as well. Thanks. That was the right word.
Yeah, I agree. I certainly don't have any knowledge of that being helpful. As I said before, there's an endless list of things people have tried. Not just medication, but also all other things. So I try to stick to the science. I can't say other things don't work. The only thing I can say is, in the absence of evidence, we need to be careful before advising this to our patients, and we need to stay clear of answering questions. I'm certainly neutral about many things, but when it comes to steam inhalations, it can probably end up causing as much harm as we think it might cause good. So I would stay away from that. So just quickly answering that question, the 47-year-old male patient, this is something we see quite commonly. But symptoms don't disappear as the COVID goes away. And this is exactly something that this questionnaire has actually said. I mean, patients tend to cough for months. Post-bronchiolitic coughs, very, very common, up to 6 months post-infection. We see this in all infections, not just COVID. And this patient has a risk factor of asthma. Certainly, I think the Xarelto and prednisone can be stopped as we would normally stop it. If the patient does not have bronchospasm or an asthmatic complication, certainly the steroids can be stopped after a 10-day course. And the Xarelto I would keep for a total of about 30 days. Absolutely. If the patient is truly hypoxic, 10 days after discharge, something's wrong. So if it can be confirmed that the patient truly in your office, if the saturation is still below 88% on room air, certainly that patient needs to be referred. And I think a scan would probably be the next port of call. A common differential here would be, especially if the patient was in hospital, you would need to consider the possibility of an acute pulmonary embolism, despite the Xarelto. It can happen. Secondly, the development of another interstitial lung complication, which is rare, but it can occur in about 4%, 5% of patients who had pneumonia. We call it organizing pneumonia, and it can plague your patients up to 3 months post-COVID. So certainly, I think important is to see whether the hypoxia is true. Certainly, if the hypoxia is not true and the patient has a normal clinical examination without any other abnormalities, maybe the CRP is now normal, certainly one can look at anxiety. But before doing that, confirm for yourself in your office, person to person, that the hypoxia is in fact there, and listen to that chest. Is a patient bronchospastic? Are there signs of DBTs maybe? And then do a CRP and a D-dimer. And, if there's anything amiss there, absolutely, I think a scan would not be a bad idea. This patient is now already probably about day 20 post-infection, and you would want to look for those complications that follow COVID rather than the COVID itself.
Thank you very much, Dr. Viviers. I would ask our colleagues, because of time constraints, to, if possible, send those questions, if there's any more questions, to the Usama and the panelists, and we'll take it from there. And in the meantime, can we have that survey put on the screen so that our esteemed colleagues can just answer those questions? There's just 10 of them. Let's take this time to do that, if possible, please.
Dr. Mzukwa, the survey will be displayed after we end the survey. So right after we end the survey, the survey will be available to all the attendees.
Okay, thank you very much then. I think I get that. Now, colleagues, because of time, I think we have come to the end of this, and we really have gathered here again, once again tonight to speak about this important topic, and from which many of us, I'm sure, we have learned a lot about. I'd like to thank the organizers of tonight's event for their planning in putting this all together, and to our speakers, Dr. Coetzee, Dr. Shange, Dr. Pillay, Dr. Viviers, for their insightful inputs. With that, I'll now formally close the session, and thank you all for attending. And please contact us if you would like more information on summer membership. Thank you so much. Please don't forget to fill in that survey, and have a peaceful night. It was an honor to be with you. Good night, colleagues.
And we have this